Welcome, everyone. You have joined the Mental Health Parity webinar series number 3, hosted by the Kansas Mental Health Coalition. The Kansas Mental Health Coalition is a roundtable advocacy organization with the primary goal of improving the lives of Kansans with mental illness. Our Mental Health Parity Committee began examining issues surrounding parity a couple of years ago and launched the webinar series this year to have an opportunity to delve more deeply into some of the issues that affect how policyholders are able to access care for behavioral health issues through their insurance. The access to insurance coverage for mental health treatment and services is an ongoing issue for many folks, whether they are trying to get that treatment through commercial insurance, whether it is under the Medicaid program, whether it is under employer-sponsored health care. And so what we want to do is kind of learn from each other about some of the issues surrounding the access to insurance coverage. And hopefully, by communicating with one another, we can improve that access to care for folks who live in Kansas and who need those services. Today, we are going to talk specifically about the emerging issues relating to mental health parity as they are addressed by some of the large employer-sponsored healthcare plans. Healthcare programs that are self-insured insurance for large employers are regulated a little bit differently than individual policies. They fall under federal jurisdiction and have some unique challenges of their own. Today, we're extremely fortunate to have some guests with us today from the Epstein Becker Green law firm, who advises employers on their policies and how they can conduct those healthcare programs for their employees. I would like to move into a program from our guests. If you would all individually just introduce yourselves and your role today, then we can get to know one another and dive into the topics. Cassandra, would you like to start?
Sorry, I was trying to find my mute button. Hi, everyone. I'm Cassandra Labise. I am a partner in our New York office at Epstein Becker & Green, where my practice focuses on employee benefits and exec comp. So I advise large employers primarily on everything related to their employee benefit plans, group health care plans, qualified retirement plans, and also compliance-related issues, including ACA and, of course, mental health parity.
I'm David Shilcutt. I'm a senior counsel for EBG. I advise plans, ASOs, PBMs, plan associations, and related entities around the country on mental health parity, in addition to other regulatory compliance, provider contracting, and managed care issues, primarily related to behavioral health. Prior to coming to EBG, I was the CMS lead for parity. I led the drafting of the parity regulations for Medicaid and CHIP markets or programs, and participated as a CMS representative on a White House task force that coordinated parity policy across markets with the Department of Labor, CISIO, OPM for the Federal Employee Health Benefits Plans, and other regulators. Prior to that, I was at SAMHSA, the Substance Abuse and Mental Health Services Administration, as the regulatory affairs lead, and led SAMHSA's work on the final regulations for commercial plans for parity. John?
Yeah, I'm John Pope. I'm a partner at Epstein Becker & Green in New York and in Florida. And I litigate, which is a little bit different perspective from Cassandra and David. I represent employers, benefit plans. I even represent providers in various types of litigations having to do with the payment of benefits, the design of benefit plans, and compliance in this particular area, mental health and mental health parity.
Amy, I think you're on mute.
Having fun trying to see all of my options on the screen. I'm not sure which of you wanted to start today, but we will. But did you
Sure.
want,
I'm
did
happy
you want to
lead.
share your
If you could-
screen?
Yeah, if you could enable me, thanks.
Well, I think
Yeah.
you're already enabled. Is it not?
It says host disabled participant screen sharing.
All right, I got it right here.
Okay. I could email you the slides.
There you go.
Okay. And could you confirm the timing for today's call? I wasn't sure if you had something else on the agenda.
No, we'd like to hear from you, and then we'll have a little bit of time for questions and answers with the goal of wrapping up before 1 o'clock.
Okay. All right. So thanks everybody for joining. Briefly, NAPIA is fundamentally a consumer protection anti-discrimination statute. And so it means that health and plans and insurers must ensure that benefit design and delivery does not discriminate against individuals with mental health conditions or substance use disorders. I think that consumer protection aspect becomes relevant with regard to certain types of limits like provider reimbursement. And so that's something to keep in mind, that ultimately the goal is to protect consumers. And the key requirement fundamentally for most of what we're going to be talking about is to ensure that limits on behavioral health benefits are applied in a manner that is comparable to and no more stringent than the application of those limits to medical and surgical benefits. When I think about parity, I generally divide it into 3 buckets. We're going to be talking about primarily today about non-quantitative treatment limits. There are separate requirements for cost sharing that we won't get into as much, but in terms of non-quantitative treatment limits, or NQTLs, the first bucket is utilization management. So prior authorization, concurrent review, medical necessity criteria, et cetera. The types of things that regulators are looking for in this bucket include application of a certain type of limit, like prior authorization, to all inpatient behavioral health services, but not all inpatient med-surg services, or application of a certain type of limit, like prior authorization, to some outpatient behavioral health services, but not to any outpatient med-surg services. They look for things like disproportionate denial rates for authorizations or things like that, failure to adhere to the medical evidence in terms of designing these policies, hidden quantitative limits. For example, in a medical necessity policy that says you can only get a certain number of urine drug tests within a given period of time. So if you ask the ASO, do you have any quantitative limits? They may say no. And the person who's responding may not know about it. The information about this types of information is often dispersed across a large number of people within any given company. And so often you need a strategy to know what types of questions to ask, how to follow up to determine what are these limits and how are they getting applied. The second bucket that I think about is prescription drug benefits. There's a lot of overlap with utilization management on the last slide. I mean, this is really all about utilization management, but because prescription drugs are differently, that coverage is designed and applied differently from inpatient, outpatient emergency benefits. In my mind, it helps to think of it as a separate bucket. There's different people involved, different policies and procedures, often a different company, if there's a prescription drug benefits management company or PBM, et cetera. The types of things that regulators are looking for in this bucket are disproportionate tiering of behavioral health drugs, so like preferred versus non-preferred tiers, disproportionate numbers of step therapy steps, like how many drugs do you have to fail on before you can get to the one that the provider originally prescribed. They look at denial rates for prior authorization or step therapy exception requests. They look at the medical evidence sometimes to support a step therapy requirement. Does the evidence really support having 3 steps versus 4 steps? Or does the evidence really support that there's a safety concern for this drug, that type of thing? And finally, one thing I've seen come up a few times is that many plans have a distinction between maintenance and non-maintenance drugs. That label has implications for things like quantity limits. Can you get a 30-day fill, 60-day fill, things like that? And I've seen regulators inquire into why certain behavioral health drugs didn't get that maintenance flag. The third bucket is by far the most complicated. My slide hasn't, somehow I didn't fill. Provider reimbursement is the third bucket. This is by far the most complex. There's the least certainty around what this means from a regulatory compliance perspective. The theory is that behavioral health providers there are shortages of behavioral health providers. There's research out there that suggests that behavioral health providers are paid disproportionately low rates, both in network and out of network, and that contributes to access concerns. So the types of things that regulators are looking for here, they'll ask for comparisons to Medicare fee schedule rates as a benchmark. They'll look at out-of-network utilization rates. In general, this is the most complex because the regulators have the least understanding of how reimbursement rates are determined in the first place. And so it can be very complex to convince them that your methodology for setting those reimbursement rates is in fact comparable and no more stringent. A couple beyond those 3 buckets that I think of in terms of how to develop the comparative analyses, providers also look for some benefit design. The regulators will look at the benefit booklet, the explanation of coverage or summary plan description, to see, are there other things in there that look like limits, sort of non-standard limits? And often this takes the form of a benefit exclusion or offering certain add-ons like travel benefits or telehealth or things like that for a limited set of services that may not include behavioral health. And so it's applied behavior analysis, any limits on that, treatment planning requirements, provider experience or education requirements, nutritional counseling, care manager requirements. There's a whole list there. I won't get caught up in it now, but I would encourage you to review that. We will circulate the slides after the presentation. The last thing that is a key risk to be concerned about is that the Consolidated Appropriations Act of 2021 created an affirmative requirement to document compliance with parity for non-quantitative treatment limits. There's a 5-step framework in statute that you have to go through that says you identify the NQTL type, you identify the factors used to determine which benefits you're going to apply the NQTL to, what are the sources, evidentiary standards, et cetera. Most of the findings to date by regulators are not that the plan is doing something that is more stringent or discriminatory, but simply that the plan has inadequately explained how they know whether it's comparable or no more stringent. And so there's a lot of ambiguity about what the minimum threshold is. We're expecting regulations any day now. There's been a little bit of guidance in the form of FAQs, but we don't have a model. We don't really know a lot about what that threshold is to be good enough, but we do have a lot of evidence about what regulators have determined to not be good enough. And so conclusory assertions, if you just say we do it the same on both sides, if you provide reporting that doesn't address specific terms in the SPD or that ignores certain language in the summary plan document. If you provide lots of attachment and say, look, here's all our P&Ps, here's all of our data, you figure it out. The regulators will say, no, you have to do the analysis and tell us whether it shows comparability. So a variety of things like that. The 2021 report to Congress has a fair amount of detail on things that that they have found to be non-compliant. And so you can, I would encourage you to review that for further information. Finally, just to speak briefly about litigation. So we're responding to regulators, but there's also a really high volume of litigation around MAPIA. I mean, almost every day there are lawsuits filed that come across my desk that there include a MAPIA violation allegation. Often it's just sort of like a Me Too thing. If they're going to dispute anything that's related to behavioral health coverage or payment, then they're going to say it's parity as well. But some of the themes are medical necessity criteria. And there, the Whitby United Behavioral Health case is really the landmark case. We could spend a whole hour just talking about that one. Provider reimbursement strategies, going back to what I was saying before about provider shortages. Plans right now often don't have a very good way of explaining how they set their reimbursement rates. Residential treatment, and then in particular wilderness therapy, that's probably the highest volume. So these residential denials, mostly out of network. And finally, availability and adequacy of documentation. So there's been at least one case, and I would anticipate more to come, where the regulators are saying that the documentation is not good enough. And so the plaintiffs are also going to start folding that claim into their suits. So John, you want to talk a little bit about how liability gets apportioned between the plan sponsor and the ASO?
Sure, David. Thank you. Let's talk about how this even comes to arise. And as the prior slide that David showed indicates, you get a lot of private claimants, or you get the aggregation of the claims of a lot of private individuals brought by providers as a way to get this into the courts. Often a large claim has not been paid. For example, when you do residential treatment for an adolescent and who has mental health or substance abuse issues, and only some of it's paid, or other standards are placed up there. So if it's a insured plan, it's going to be primarily against the insurer, but there's also going to be allegations against the plan sponsor saying that they haven't adequately monitored the ASO or the insurer. They haven't made sure that their plan is compliant, and that ultimately is a responsibility of whoever puts the plan together. It needs to be compliant, and whether you buy it as an insurance product or you're having it designed in a more custom manner, it falls to the plan sponsor to make sure that what is being offered meets the standards of the law. And if you have a self-funded plan, of course, that is more obvious. Class actions like the Witt case are running around out there and really raising the stakes and providing a way that a lot of these claims get dealt with together. Remarkably, after a federal district judge out in California issued a sweeping order in Witt that required, as David noted, reprocessing of tens of thousands of claims, the appellate court set it all aside and said, nope, no problem here. So, and they did it in what we call an unpublished order, which means it's not even a precedent that you can run around and cite. So it leaves the playing field open for this litigation to go on and on and on. So that's how it's going to come out of private claimants and how it's going to break down. One of the things you have to be concerned about, though, is that this is not an area that is just brought by private plaintiffs. The Department of Labor is intensely interested, deeply involved, and has listed this as a priority area for compliance. Go to their website, look at the EBSA, the Employee Benefit Security Agency in the DOL, and those folks, that's front page of their website. This is a very, very high priority for them. The NQTL stuff is very high priority for them because it's new. It's the most, they consider it the most important innovation because the law just embodied what they had been wanting the law to embody for a few years now. So they are issuing subpoenas, they are making inquiries, they're even asking for depositions from ASOs. And that's got to be a concern even for those who aren't in the insurer space or the ASO space, because the information that they're gathering when they speak to those companies is then trickled out to look for non-compliance by the plan sponsors themselves. In fact, in a recent litigation, but this wasn't a mental health parity one, but it's an illustrative of it. In a recent litigation going after a company, Alight, which does record keeping in the pension space, when Alight asked to be able to strip identifying information about particular customers that they were serving, the plan sponsors, from what they turned over to the DOL said no, and the court agreed, saying, how else is DOL supposed to know who's breaking the law? And so from the DOL's point of view, they're going, and it's a smart move, they're going to the people who are the central repositories of more of this information, pulling out who is in non-compliance from that information, and then going out to them, because they couldn't possibly find every employer or every plan. I mean, how high a priority are they going to put on a lot of Kansas? And I'm from Iowa, so we look up to Kansas. But how high a priority are they going to put on Kansas when they have Fortune 500 companies in New York and other places? Well, they don't have to go directly to those institutions to find out if there's non-compliance. They can go through, if you use one of the Blues as your ASO, or if you use United Healthcare, one of those, they can go to those and come up with the information from that agency that will then lead them back down to you. And it's a much more efficient manner from the government side to find out who they believe is in non-compliance and to follow up with them. And that means that there's a very important partnership that you have to make with your administrators, and that is you have to find out from them, are you in compliance? Get your reassurances about compliance, and find out if they're putting together the documentation to allow you to show that you're in compliance, because that's going to be a big part of it in the end. If the DOL ends up at your door, do you have the documentation? And if that requires something from them, then you need to partner with them to make sure that you have gotten that information together. And now I think Cassandra has many important things to say.
Thanks, John. So as John and David brought up, we have this huge enforcement initiative by the DOL in which they're really making it a priority to look at how plans are complying with parity requirements. We had the CAA that kind of codified the comparative analysis requirement and really created a timeline as to when plan sponsors should be providing the analysis upon request, not only from the DOL, but also from beneficiaries. And in light of all this, in light of the litigation risk, in light of the enforcement initiative, what can plan sponsors do on the back end in order to partner with the ASOs, but also protect themselves as much as possible? Because as John said, at the end of the day, the plan sponsor is responsible for ensuring that whatever product that they are offering to their participants are compliant with law. And so one of the things that you may want to do is look at your service provider agreements and look at renegotiating terms and highlighting roles and responsibilities in the actual agreement in light of all of this. Prior to the CAA and prior to the enforcement initiative, I don't think I saw a service provider agreement that specifically outlined parity roles and responsibilities or requirements. I think it's important now to put in language that kind of ensures who is responsible. What are the timelines providing documentation, ensuring that the ASO agrees that they will partner with you in order and collaborate with you in order to ensure that they will be providing information timely and upon request, because the regulators are not providing that much time to comply with any document requests they have, ensuring that they will continue to partner with you in order to provide documents in a timely manner upon request, in order to ensure that you are not violating, you're not getting on the bad side of the DOL as part of this enforcement initiative. look at your indemnification provisions and see if you can beef those up in a manner that protects yourself even more. So even if you, you know, a participant or a regulator comes in and you know the plan sponsor is left paying penalties outside of, you know, re-adjudication of claims, but actually have a penalty assessment, and the penalty assessment is tied to like a provider reimbursement rate that's really set by, you know, the actual ASO and not really the plan. You know, how will you be reimbursed for that? Will the ASO be able to reimburse you for those type of penalties and costs? Looking at whether your customization aspects of your plan, are you just getting a product from the ASO that they're offering to a wide variety? It's similar to maybe a fully insured product that they also offer, or are you customizing it in a manner that really can run afoul of parity requirements? Asking those questions, how does it differ? What, you know, are there concerns about the customizations? One of the things I'm starting to see from some ASOs is they're reaching out proactively to plan sponsors and saying, we are updating these documents, these benefit booklets, because we recognize that your customized language could run afoul of parity rules. Start having these dialogues to figure out what the differences are and outlining all of that in agreements. As you know, the ASOs don't like changing their form documents, but as much as you can put into those documents to protect yourself as a plan sponsor and at least outline the roles and responsibilities of all the parties, it goes a long way when there is an investigation by the DOL, or if there is a litigation, you know, you can refer back and say, I need these documents provided by X amount of days as agreed upon in the service provider agreement. And then they understand there's a partnership going on and there were agreed upon roles here. I think early on when the DOL started having their enforcement initiative, many self-funded plan sponsors, especially when they were going to their ASOs, asking questions, there was a lot of confusion about what roles each party played with regards to the data and the documentation. And so you couldn't point to a section of an agreement that said they would be providing this comparative analysis. And in many respects, the ASOs were like, well, we're responsible for fully insured plans, but not necessarily self-insured plans. Now that we are very aware, at least at some, you know, at this juncture, like the DOL will make this an enforcement initiative for a while to come. We're supposed to be getting, you know, rules that clarify some of the questions we have. Adding in anything that you can in your service provider agreements that kind of outline these roles and responsibilities will go a long way in helping, you know, if you are ever find yourself as part of a DOL audit or part of a litigation in the mental health parity space.
Yeah, just to build on a couple of those points. First, in terms of the priority from the DOL, Ali Kawar, the Assistant Secretary who leads EBSA, has said that parity enforcement is his top priority for EBSA. Second, it's helpful to know that DOL is building a dedicated team of MAPIA specialists. So they're training a group of investigators to have dedicated time and expertise for parity. So that type of infrastructure doesn't get unwound quickly. So they're obviously trying to scale up the volume of investigations that they can do, and I would not expect that to decrease in the next few years. The other thing, the point that Cassandra was making about customizations is really important. It's, you know, the ASO is having to, most ASOs have some fully insured products and spend time developing their documentation for their fully insured products. And the ASO agreement, you can get them to agree that they will make that documentation available to you, along with a customization report. So one thing that I see sometimes is that neither the ASO nor the plan really knows what the customizations are, especially in long-standing relationships. Those, for example, the list of benefits or services, or even at the service code level that are subject to prior authorization, that can be buried in coding in their software systems that it can, in some cases, has been very hard to track down and figure out, well, when did this originally happen? What are the specific codes for this specific employer plan? And who made that decision? And that can be relevant when it comes to explaining whether you can just cut and paste from the fully insured compliance analyses, or whether you need to address specific things that you as employer plan at some point told the ASO, we want you to do this. And now you're taking, and now you have to take responsibility for showing the Department of Labor that when you did that, if you're going to maintain it, if you're going to continue it going forward, that does in fact comply with parity. And that could be med-surg or behavioral health. Remember that it's a comparative analysis, so you can't just focus on the behavioral health services. You have to think about any customization on either side. So a few additional considerations. Once beyond the contract itself, some strategies for what to do to oversee the ASO. You should review their documentation. And so specifically, you should look at how are they defining what is a mental health benefit and what is an SUD benefit and what is a medical surgical benefit. That's not necessarily an obvious point. The federal law just says you have to do it in accordance with national standards. But it's not enough to just say we use the ICD-10. Which codes in the ICD-10 are going to be mental health service codes under your interpretation? There's a variety of gray areas, from developmental disabilities to intellectual disabilities, et cetera. Gender dysphoria often comes up. Autism in particular comes up a lot. Second, you need to see their actuarial testing results for the copays and coinsurance. I mentioned before, it's a different test a little bit about how to determine compliance, but that's something that they should be able to produce for you to show you that the copays and coinsurance levels that you're applying, types and levels, comply with parity. You should definitely review the comparative analyses for key NQTL types. So the FAQ 45, the most recent FAQs from the Department of Labor that address parity, identify 4 that are current priorities. It's prior authorization, concurrent review, standards for admission to a provider network, including reimbursement, which is a bit of a mouthful. And again, there's the most to unpack there. We could spend easily a whole session talking about that. And finally, out of network reimbursement rates. And then finally, you should get that customization report to say, if you give us your fully insured or your standard documentation that you're providing to state regulators for your fully insured and to other ASO customers and the self-insured side, tell us how far does this go? Is it 100%? Or does this only address 95% of our plan design, and we need to address these specific customization aspects that we as plan sponsor told you to implement and that you're doing just at our direction. Some things to think about in terms of addressing potential compliance risks. To the extent that you identify any real concerns, you want to think about attorney-client privilege so that you can communicate with the ASO about this and have a shared strategy about what to do about it under privilege. That might take the form of joint representation. There's some additional strategies that you can consider there. Think about what's the harm? What's going to come out of this? What's the financial risk in terms of, are there denied claims? Are there penalties on the table? There's certainly reputational harm to consider, given that you have under under federal statute, you have an obligation to notify your members if the department finds you out of compliance with parity, and you'll be named in a report to Congress at the end of the year that names all of the plans that were found out of compliance. What are the limits or risks, extent of the shared risk with the ASO? It can be fairly complex depending on a variety of facts and legal considerations about who ultimately is on the hook for certain things. And so that's something that you want to evaluate in terms of that indemnification requirement that Cassandra was talking about. If you have concerns, then what's the remediation plan? That might be imposed by a regulator. The Department of Labor will require a corrective action plan if they find noncompliance. Or if it's something that you identify internally, then they're going to need some reasonable time to respond. But you need to be on the same page, and you need to be checking up on them that they are implementing what they say they're going to do. And then you've got to continue to monitor the litigation, enforcement findings, reports to Congress. One really significant thing to be watching out for that Cassandra mentioned is there's a notice of proposed rulemaking that was scheduled for release in July. It's probably going to be, in my reading of the tea leaves, another 4 to 6 weeks, but hard to say. They're not saying when it's going to be available, but soonish, there will be a new notice of proposed rulemaking that will probably shed some additional light on exactly what you need to be doing. One question that I saw in the chat is how to identify which ASOs are operating in Kansas. There is a report by, I think it's the AHIP, American Medical Association puts out on the fully insured side, but for the self-insured market, you would just have to, each plan obviously knows who they're contracting with. So I'll pause there. We've got some additional content that we can go through in terms of the process for if you get an investigation by DWell, but wanted to see if there's questions before we move on.
You have answered so many of the questions that I had kind of written down in anticipation of this conversation. So thank you for being so thorough. But one of the questions that I have is, so I'm the Amy Campbell Corporation, and I see that the United States Department of Labor has set out this priority. They are not alone. Many of the state insurance departments have also been looking at how they can improve enforcement for mental health parity and to assure that policyholders are accessing mental health care. I think the pandemic made that need, even more apparent across the country. But I'm curious if you believe that this new emphasis on enforcement is something that's going to trickle down to the covered lives, to the employees of the Amy Campbell Corporation. Are they going to be able to feel this change at the end of the day?
It's a great question, and it's one that not enough people are asking. So going back to my 3 buckets: utilization management, prescription drugs, and provider reimbursement. On prescription drugs, I see the least evidence that anything is happening. With my clients, I think most of them that come to us are already relatively sophisticated. And I find that there are, a couple nits and gnats here and there, but very little that would be felt by a beneficiary. But there's also probably more research to do in terms of the underlying policies and procedures, the medical necessity requirements. And so I'm not a clinician, pharmacist or physician, and I don't think there's been a comprehensive determination that all of those medical necessity policies in fact adhere to the best evidence. But the ASOs that we work with and PBMs are pretty sophisticated, and I'm pretty impressed in general with their processes. And so I don't have a default reason to think that there's a there. For utilization management, it's mostly the same. My clients have made very few changes in substantive ways to what they're doing. The Department of Labor, one of the key things that's happening right now is the Department of Labor is saying you have to define the factors that you use to determine which services are going to be subject to prior authorization in a quantitative way, so that it's purely objective. And so if you just say, well, it's safety and quality, that we apply prior authorization when there's a safety and quality issue, how do you quantify that, or how do you define it in a black and white way to show that it's consistent every time? And so some companies are taking strategies to develop sort of an algorithmic approach where you have a weighted score and you assign scores to different types of evidence and go through that process. That's a big undertaking. There's a lot of cost to that. But in general, I'm not seeing a lot of differences in terms of the outcomes. There are a few plans out there I've seen where they have prior authorization requirements for medication-assisted treatment to treat addictions. Don't do that. The evidence isn't there. I don't know why they're doing that. Nobody should be doing that. It's not often. So there's a few examples out there of some specific plans that have some specific limits that need to be changed. But market-wide, the trend is pretty marginal. For provider reimbursement, that's the biggest open question. there's really a lot of debate about how to define comparability for provider reimbursement, because it's apples and oranges. How do you compare your reimbursement to a licensed clinical social worker to your reimbursement to a radiologist? So there's some theories about how to do that. There's a seminal report by Milliman that provides a strong de facto case for disparities. But I think there's some strong rebuttals that can be provided. I don't know how that's going to shake out, but that's I think the most likely thing, if there is going to be real system change, it's going to be on the reimbursement side, and it's going to be because somebody comes out with a strong methodology to say this is the right way to do it, and this is what plans and ASOs need to be doing in order to achieve comparability. But that to date has not happened.
So my follow-up to that is, and I have worked for the Kansas Mental Health Coalition for more than 20 years. And when I was first hired, it was to pursue a state level parity law. And so that took several years, and it was very educational, and it began my long history of educating myself regarding insurance and kind of how that works or how it doesn't work. So my question to you then is, do you think that families who are under these policies will find better opportunities to communicate with their employers about what's happening with their policy and with their health care? It seems like this enforcement might lead companies to take more responsibility for how it is or isn't working instead of handing it off to their program administrators.
That's another great question. One thing I didn't talk about here is the disclosure requirements under parity. So plans have to make these comparative analyses available to members upon request. What exactly they make available to members, in theory, the simplest way to think about it is it should be the same thing that they give to regulators, but not everybody does that, and there's no real guidance. But you can ask for the documentation. You can ask for the underlying policies and procedures. You can ask for the medical necessity policies. And so, I mean, first, reviewing, if you find things in those medical necessity policies, if clinicians look at them and have concerns about what's in there, then you can raise concerns under parity and say, this doesn't seem to adhere to the evidence. We're going to assume that you are adhering to the medical evidence on the med-surg side. So there's a presumption of a disparity, and push the ASO to defend, whatever's in the policy. The other thing that you can do is use this as a springboard for saying, regardless of parity, like, here's the provider network that we need. Here's the data on access that shows that there is inadequate access. Can you put together data to show that it is comparable, to challenge them that way? But like, here's what we think what inadequate network should look like. And as an employer, especially as employer coalitions, then you can negotiate with the ASO to say, here's what we think we need for business purposes, which is in some ways more powerful than what we need for regulatory compliance purposes.
And I wanted to jump in and say what I've been seeing from the employer perspective, I think especially directly related to the pandemic, they've been trying to figure out ways to expand access to behavioral health services in more non-traditional ways while still working with their ASOs. So for instance, they might do direct contracting relationships with a major hospital system that has a large database of behavioral health providers and use their ASO to help kind of bridge the gap so that the members themselves don't feel like there is a gap in coverage. To use their employee assistance program to provide some base level behavioral health services in a limited capacity. And once that's reached, encourage them and help them find access to a provider within their healthcare network to continue the relationship or, kind of figure out a way to assist. I think a lot of employers are trying unique ways to help participants, especially because everyone's very vocal about the need for mental health services in light of the pandemic, we still do have lack of access. I think if you're in a larger, city, of course, it's so much easier than maybe if they have employees in more rural areas. So there's still some of that. And so they're trying to kind of use telehealth as a mechanism to also create more access. So I think there is, at least from my perspective, I'm seeing a lot of conversation more than I've seen, in the past, a lot of conversation of how do we provide access in non-traditional ways to our members who are either asking for it or they know they're going to ask for it. They might not know they need it, but they know eventually, because everyone's working from home, for instance, they might need to talk to someone for a reason, for an issue, or they might have a dependent who requires a certain level of care and they're having trouble finding, because we all heard those reports of people waiting weeks or months in order to get like doctor's appointments to see certain types of providers. So I think that's what you're starting to see, at least what I'm starting to see from like the plan sponsor perspective. So if they're an employer trying to think about what else they can do, those are some of the options that other employers are exploring to try to kind of bridge the gap in light of some of their own concerns.
And if I can add just one thing, which is litigation is the worst way to make any of that change. It does plaintiffs' lawyers get wealthy. I get a lot of business, but there's not a lot of change. And I think that the Witt case and what happened with it, where there was years of litigation, a big class action injunction, and the appellate court threw it out. And they threw it out in, on the secret docket sort of thing. So, it's a horrible approach to go. I think you have to look at getting the regulators or the legislators involved if you want to actually get some real change.
Yeah, I see a question in the chat box about awareness of MAPIA among employers in the market. And I think it's kind of a similar answer. Like how much should you focus on publicizing or promoting MAPIA awareness to employers, to members, et cetera. I think MAPIA enforcement is often the least best way to get change. I think it's much more effective to identify the problem and identify the change that you want as advocates. You can bring in lawyers like us to frame it up from a litigation perspective. You can bring in lawyers like us and consultants to work on it from a regulatory compliance perspective. But it gets so technical and so complex from a parity compliance perspective that it's really easy to lose sight of what matters, like what is going to actually create change that's going to matter to the members. And that's where I think the ASOs are much more receptive to discussions and problem solving. And it's a simpler conversation, and I think it's often much more meaningful. Parity can be that in your back pocket, sort of as an implicit or explicit sort of threat, but it's not a great framework for collaborative discussion about change.
And I think those are excellent points. I would counter that by saying that when you're talking to the people who run health plans, and when you're talking to policymakers, and when you're talking to regulators, you end up in this very strange no man's land where they may be trying to solve a problem for one constituent, which often does not have broad positive impacts, or they are overwhelmed by the problem and don't know how to address it. When the new focus that we're seeing across the country, which hopefully will avoid a lot of this future litigation, I think the litigation is a kind of a symptom of an underlying dissatisfaction with the way the system's working today. And agree that litigation is, it's just about the worst way to go about trying to cause change. But I think that it shows that what's not working. And I'm very hopeful that what you have talked about here and the good advice that you can give to your clients indicates that employers will engage a little more robustly in this game. And additionally, the issues of everybody needing additional employees will encourage them to want to compete by offering, good coverage, good health care. It used to be back in the day, people flocked to companies for jobs if they knew they had a good health care plan. And I'm hoping that we're going to be seeing that come back as well, because I think that these business leaders have the ability to affect far more change internally than having government tell them they have to do it. So it's a constant battle between the cost and the benefits. Another question that I was going to ask you, and one thing that doesn't ever get discussed in this, is you mentioned outcomes, and it would be really nice if there was some sort of comprehensive data about the outcomes, that when we see access to care being provided without having to jump through 10,000 hoops, which a family with a teenager with severe mental illness probably is less equipped to jump through than maybe what they need to be, then there can be better outcomes for those families and happier employees in the long run. So I really appreciate the advice that you've given us today. I know you had some additional content, but I'm not sure that is there anything you'd like to call out from that before we kind of wrap up?
No, I think we hit the key substantive points here. It's just some extra process that I'd be happy to discuss it if folks would like at a future date.
Absolutely. I think what you've provided us today is extraordinary. I want to thank you for your time. I know that your time is valuable, and we really appreciate that you were willing to share with us today. If there's, you'll send us the slides and we'll make that available to the folks who participated today in this program. This will be, the recording will be linked to our website so that members of the Kansas Mental Health Coalition and others can access it if they need to. We will be having a 4th webinar for the Mental Health Parity series, and those notices will go out as soon as we get that scheduled. We expect to have that in late September. So thank you everyone for participating today, and I hope you have a fabulous afternoon.